Good evening, ladies and gentlemen. First, I'd like to thank the organizers of the 6th Annual Scientific Meeting of the Iraqi Association for Dental Research. Thank you so much for having me today to join this meeting. Okay, allow me today to share with you a very important and a significant topic within the field of oral diagnosis, which is the early detection and recognition of the pre-malignant and the malignant oral lesions. My study regarding this subject was the diagnostic efficacy of visually enhanced lesion scope in the identifying of the benign, dysplastic, and cancerous oral lesions. I am with you, Surur Ali Jabbar, from College of Dentistry, University of Basra, Master of Oral Medicine, College of Dentistry, University of Baghdad. The study was supervised by Dr. Fawaz Dawood Aswad. So, why we have to focus and stand up with our knowledge regarding this field, the fields of the early detection and the identification of the suspicious oral lesions. That's because the early detections of the pre-malignant and malignant lesions is superior to prevention and considered to be essential to improve the survival rates of the patients. But awkwardly, most patients diagnosed lately in a progressive state with lymph nodes separating and metastasis, thus suggesting the recent day recognition techniques that depends on the examination by the naked eye alone are inadequate. So, the development of early identification approach involving the enhanced visualization methods could be beneficial regarding this subject. As we all know, the biopsy considered to be as the gold standard within the field of oral diagnosis, but it is limited by the sampling bias as a result of the site selections, and the treatment clinicians required to perform the biopsy correctly and expert pathologists and a prolonged time for diagnosis is required, and also suffering from the inter-observer and the intra-observer variance, and also suffering from the patient morbidity and discomfort. So there is a clinical need for a diagnostic adjunct that augment the conventional oral examinations. These adjuncts may help the clinicians to decide which lesions need a biopsy by distinguishing the high-risk oral potentially pre-malignant disorder that harboring dysplasia or cancer from the low oral potentially pre-malignant disorders and differentiated it from the other mucosal lesions, and also for saving as a biopsy guidance and for longitudinally monitoring the patient if repeated biopsy procedures are necessary. Okay, let me take you to a rapid revision regarding the common diagnostic adjuncts that have been used in the oral diagnosis. These adjuncts including the vital toluidine blue, the oral brush biopsy, acetowhitening, and the optical biopsy methods. This study concerning with the optical biopsy methods, which is the tissue fluorescent spectroscopy by the VEL device. The history of the VEL, the autofluorescent examinations belong to 1924, and the successive studies and experiments continue till 1998. So, the great revolutions regarding this field on 2006, where the VEL device were introduced by the LE Dental Company. The principle of this approach, depending on the normal depending on the normal autofluorescent characteristic of the epithelium. So, when the blue excitation lights emitted from the viloscopy device in a wavelength about 460. So there is abundance of molecules within the epitheliums and the underneath stroma. These molecules are calling the fluorophores. These fluorophores molecules such as the collagen, the elastin, and the NADH, and the NAD, and the aromatic ammonia compound, and the porphyrins. These fluorophores molecules, when they are excited by the blue excitation lights from the viloscopy, going to emitting an energy with a lesser energy but with a longer wavelengths. This wavelengths appearing within the green spectrum as reflecting as a green color in a longer wavelength about 550. But when there is destruction of these molecules, such as the stromal collagen and the elastin, in case of either dysplasia, malignancy, or inflammatory lesions, so there is a loss of autofluorescent characteristic of the tissue, resulting in a loss of fluorescence characteristic and the area appearing as a dark or a black color in comparison within the normal area that's appearing as a green color. As we see in these pictures, after the application of the viloscopy examination, the area appearing as an area of visual fluorescent retention. This is the normal fluorescence features of the mucosa, while this visual fluorescent loss, which is the abnormal fluorescent characteristic of the mucosa. But unfortunately, this approach was limited by the false positive result because a different histologically distant lesions having a different or similar autofluorescence features. As we see in this table, we have the epithelial hyperaplasia showing no changes within the autofluorescence characteristic, while the dysplasia and the invasive carcinoma showing a complete or partial loss of fluorescence, while the infectious and vesicular lesions showing a complete also or partial loss, that means similar to dysplasia and invasive carcinoma, while the submucous fibrosis showing an enhanced autofluorescence characteristic, while the amalgam pigmentation and focal melanosis showing a complete loss of autofluorescence. So we have to combine the clinical examinations besides the fluorescent examination by the viloscopy to reach an accurate diagnosis and decreasing the false positive results, indicated as the low specificity of the viloscopy examinations. So the aims of the study was to obtain an autofluorescent data on a variety of histopathologically distant oral lesions and the assessment of the direct autofluorescent examination validity by the viloscopy in identifying the dysplastic and malignant oral mucosal lesions by using the viloscopy and the engagement with the histopathological examination as the standard. The design of the study was a cross-sectional study involving 50 patients having suspicious oral soft tissue lesions, and after recording of the patient's information and patient history in the patient's data sheets, then the patients prone to conventional oral examinations, then followed by the viloscopy examination, and biopsy and histopathological examination for the suspicious sites. Okay, the biloscopy device consisting of the biloscopy charging cradle and cable, the biloscopy handpiece, the aseptic anti-fog barrier and the aseptic anti-fog lens, and the image adapter and iPhone for capturing of the image during the examination. And this also a septic barrier for the handpiece and the protective patient's eyeglass. The procedure of the examination involves, after the dimming and decreasing of the clinic lightening, the biloscopy handpiece directed toward the patient mouth and starting for visualizations of the entire mucosal surface as the labial mucosa, the buccal mucosa, tongue, floor of the mouth, and the hard and soft palate, and maintaining a distance for about 3 to 4 inches to obtain a clear and decreasing the blurring during the examination. After that, recording the lesions and the outcome of the examinations. As we see in these pictures, we have these red lesions within the clinical examination, by biloscopy examination showing this area, dark or black area, that defined as a visual fluorescent loss, while this ulcerative lesions showing this area of visual fluorescent retentions as this green color. We see the difference between these two pictures. This is the area of visual fluorescent loss, while this is the visual fluorescent retention as a green color, normal green color, while this is the abnormal dark color. So, the biloscopy examination outcome, the sensitivity and specificity. The sensitivity of the examinations of the biloscopy or any other device can be defined as how accurately that the examination truly identifying that the lesions truly and correctly having dysplasia or oral squamous cell carcinoma, while the specificity can be defined as the how accurately that the examination can ruling out and excluding that the lesions having a malignancy or dysplasia. So, the result of the study leading us to a specificity and sensitivity of the biloscopy examination after comparing with the histopathological diagnosis as the standard, then comparing the biloscopy examination with the histopathological examination, the result showing a sensitivity of about 76.9%, while the specificity was about 64.8%. This results resulting from in that the benign lesions that's found in the study was a 24 lesion showing an area of visual fluorescent retention as a negative finding, while 30 lesions showing a visual fluorescent loss as a positive finding, while the dysplasia showing one case showing a visual fluorescent retention, while 6 cases showing a visual fluorescent loss as a true positive result. While regarding the oral squamous cell carcinoma, we having 2 cases showing a visual fluorescent retention as a false negative result, while 4 cases showing a visual fluorescent loss as a true positive result. So let's move to the clinical image. Regarding these pictures, the clinical examination demonstrated a well-defined red lesions. After the viloscopy examination, this area showing a visual fluorescent loss as this black or dark area. That's later defined by the diagnosed by the histopathological examination as a mild dysplasia. So this case indicated to be as a true positive result of the viloscopy examinations. And then let's move to the other pictures. The first picture, we have this white lesions after the viloscopy examinations showing this visual fluorescent loss. After the histopathological examinations, the lesions diagnosed of being an oral lichen planus. So this case described as a false positive result because this area showing an visual fluorescent loss. That's giving us a suspicion of dysplasia or carcinoma, but it was diagnosed by histopathological examination as an oral lichen planus. Regarding the second picture, we have these extensive lesions after the viloscopy examination showing a visual fluorescent retention as this green color. But after the histopathological examinations, it was diagnosed as a squamous cell carcinoma. This result described as a false negative result because an explanation of this because of the thickened keratin layers within the lesions that masking the underneath visual fluorescent loss and the underneath destructions of the fluorophores. So the keratin layer masking this destruction and appearing as a visual fluorescent retention. Then let's move to the third picture. We have this chronic ulcerative lesions. After this ulcerative region was about 3 months. After the histopathological examinations is diagnosed as chronic ulcerative lesions, and this area showing a visual fluorescent retention as a true negative result, meaning a negative of dysplasia or malignancy. The last picture, this white lesion after the histopathological examination diagnosed as a mild, also as a mild dysplastic lesions. So showing the viloscopy examination showing this area of visual fluorescent loss as this dark or black area. So this case described as a true positive result of the viloscopy examination. So that leads us to a conclusion that the direct visual fluorescent examination by the viloscopy considered to be adjunctive to the conventional oral examination in a varying aspect of clinical practice as simple, fast, cost-effective clinical adjunct to the conventional examination, but rather than a definite diagnosis for the pre-malignant and irre-malignant lesions, but could be used as a screening tool to detect a lesion before it's being obvious on the surface. And in our conclusion, that the use of the viloscopy in specialized centers required a significant understanding of the mucosal pathology and the interpretation of results requiring skills and training to reduce the false positive results. And finally, in spite of having a reasonable sensitivity, the high number of the false positive results limits its efficiency as an adjunct. So, thank you for your listening and hope to meet you again. Thank you very much.